Thanks. So I'm assuming you can all see my slides. Can you hear me nice and clearly? Okay.
Yes, we can.
So, yeah, okay. Thank you so much. Thanks, Jared and the team for inviting me to present on this forum this morning. And as mentioned, or as per the program, I'll be giving a gastrointestinal perspective on antimicrobial prescribing, as well as some concepts of antimicrobial stewardship. We know that the gastrointestinal tract is quite a vast organ system. The luminal system spans all the way from the mouth up until the anus. And we also have then some of the adjunctive organisms, such as your hepatobiliary organisms, as well as your pancreas and some other smaller organisms that are associated with the gastrointestinal system, as well as its functioning. And in fact, all of these parts of the gastrointestinal tract can be infected in one or another way. There are many guideline statements that address like specific management principles. What I'll do today is just touch on a few that we see commonly, as well as some that haven't been updated, at least to my knowledge. So just like with all our other organ systems, there is normal flora that colonizes the gastrointestinal tract. In our instances, we call it the gut microbiome. And on the left-hand side, you can see I've circled some of the bacterium as well as the fungi that affect or that normally colonize the GI tract in a normal patient who comes from the community. On the right-hand side, you can see there's a slight change in the flora, not quite as much as in the other systems, but this is obviously due to exposure to some antimicrobial agents, as well as some contamination and spread within healthcare facilities. So it's important to know this microbiome, because once you do have a nidus of infection, knowledge of this may allow us then to pick an appropriate empiric therapy. So the first entity I'd like to discuss today is Helicobacter pylori. We all know this infection quite well. It's a gram-negative bacillus, and it's quite endemic throughout the whole entire world. In the Western world, due to a lot of test and trace strategies, it has become a little bit less prevalent. I believe the latest data shows that it's about 50%, while it still does dominate within our context. In terms of how it presents, I'm sure we've all seen it in one way or another. Typically, from a gastrointestinal point of view, we have both benign and malignant disease. However, there are some other extra gastric manifestations of this organism or of this infection, and that we need to address. If we look at chronic infection specifically, and this is the one that we might know a little bit more about, we have simple chronic gastritis, which is the vast majority of how patients will present with chronic infection of H. pylori. And this is typically a mixed gastritis, and the significance of this is not quite known. And so we don't tend to treat these patients. What we do see a lot more commonly, which is a lot more visceral for us, is your duodenal ulcer phenotype. And this happens in about 10 to 15% of patients with Helicobacter pylori infection. And this is where you have an antral predominant gastritis that leads to high acid or increased acid secretion and duodenal ulceration. And then complications of this, which we see quite often, is upper GI bleed, so a perforation. We could also have a stricture or benign stricture formation and bleeding. And this is obviously contrasted to the gastric cancer, gastric ulcer phenotype of chronic Helicobacter pylori infection. And this happens in a very small minority of the patients. And the difference here is that the bacterium affects the fundus and the corpus of the stomach. And this leads to achlorhydria in this instance, with an increase in gastrin formation. And then this stimulates gastric ulcer formation, as well as for the more severe kind of endpoint, gastric cancer. And of course, I did mention there are some other extra gastric manifestations. Sometimes unexplained iron deficiency can be explained by Helicobacter pylori, as well as ITP. And there are various guidelines and statements governing how we should work these patients up. So the quick one on the workup. Typically, patients who have no danger signs, we can use a test and treat strategy, which is basically using a urea breath test. We can use stool antigen testing, or indeed even serology, although this is not quite as sensitive as your other modalities. And then in instances where you have danger signs or the so-called danger signs, patient who has a loss of weight, family history, advanced age, or history of an upper GI bleed, you would make this diagnosis on endoscopy. But what I wanted to focus on was the treatment. In our setting here in South Africa, standard of care is triple therapy, which is a regimen based on the PPI, amoxicillin, as well as metronidazole. As you can see in this table on the left, there's a meta-analysis that showed the efficacy of the different regimens that we have for treatment of Helicobacter. And as you can see, our regimen doesn't appear here. And the reason being is that these regimens show efficacy of around about 90%, while this triple therapy that we use in our country is about 70%. And the reason I wanted to also emphasize or highlight this is that with other infectious diseases or maybe other indications for antimicrobial therapy, we're governed often, or we should be governed by the clinical response as well as your biochemical response. And then your duration will then be tailored according to that, as we saw in our previous talks. However, in this instance, the duration has to be strict to complete this course so that we get complete eradication of this organism. The other thing I just wanted to touch on a little bit is the resistance. Typically, or at least previously in our context, we didn't have much in the way of clarithromycin and or metronidazole resistance. There was possibly a paucity of data coming out, but certainly is an issue worldwide, at least in the Western world. But there have been there's been a little bit of data that has come out of South Africa, I believe in Cape Town, as well as Prof. Ali in Mbelle, that has shown that we are having increasing both clarithromycin as well as metronidazole resistance. So we might have to look at our newer guidelines as either having a quadruple base therapy. I know we do have bismuth in the country, however, it is on back order, I think, because of the COVID pandemic, or indeed looking at some of the other sequential or concomitant regimens, or using other antimicrobials. So that's just something to think about. The second entity I'd like to discuss this morning is your diarrheal diseases. We know that this is quite a common condition that we all encounter. Certainly in the medical department, the vast majority of our infectious or our admissions have a diarrheal component. We know that it can be classified based on its duration. So acute diarrhea is less than 2 weeks, up to chronic diarrhea more than 4 weeks, or we can further classify it based on the mechanism of the diarrhea. So osmotic or secretory diarrhea typically causes a watery diarrhea. It might be a nocturnal diarrhea, and this is can be contrasted to a malabsorptive diarrheas, which is we typically find it kind of we find in our small bowel causes of diarrhea, and not typically our infectious causes, except for perhaps intestinal tuberculosis. But this is typically associated with your malabsorption syndromes. So you get a fatty diarrhea associated with bloating, steatorrhea, and the sorts. And of course, commonly that we will encounter in patients with the infectious diarrheas is our inflammatory diarrheas. And these, or the typical symptoms, clinical features of inflammatory diarrhea are obviously fever, but you may have a bloody diarrhea as well as mucus within the stool, or white blood cells within the stool. And then when we look at some of the causes of diarrhea, of course, the theme of today is infection and antimicrobial prescription. But just to remind that there are many other causes of diarrheas particularly, and they may have different mechanisms of causing diarrhea. So if we look at some of the infectious causes, which is the table in the middle, most often your acute diarrheas are viral, and particularly driven by rotavirus infection. And most common, or most often, these are self-limiting, generally not severe. However, there are some cases where they can be, which I'll touch on a little bit later. But you can see we can also have our bacterial causes of diarrhea. And the ones we tend to worry about a little bit more are those that cause dysentery. So if you can see in the middle column, towards the middle, you will some of those organisms there they cause dysentery, and the mechanism of which is either invasion, invasion, which is invasion of the bacterium itself into the gut wall, or toxin, introtoxin, or toxin formation, which then mediates this diarrhea. And of course, not to forget some of our parasitic causes, as well as rarely some worms being a cause of acute diarrhea. It's also important to bear in mind some of the specific risk groups. Of course, we do know those who are at high risk are those extremes of ages. We know that immunodeficiency, particularly in our context, HIV infection, but also to remind of other causes or other scenarios that we must consider, particularly those with a travel history in the setting of acute diarrhea. So traveler's diarrhea becomes important for us to consider, as well as perhaps if there's an epidemic or an endemic, if there's a household contact or community spread, these are also to be borne in mind when we approach a patient. So a quick one on the epidemiology. This was an interesting table found from the latest global burden of diseases data. And overall mortality, as you can see, well, the color coding here, the pink, blue is our infectious diseases or communicable diseases. Diarrheal diseases were the third most common cause of mortality in 1990. And this is overall, all ages and everywhere in the world, at least where they were getting the data. And 30 years later, it's still quite highly prevalent. As you can see, it's now fallen from third most common cause to fifth most common. And this is driven by it's driven mostly by these infectious diseases in our pediatric population, so our neonates as well as our young children. And as you can see, as we get to our young adolescents and young adults, so the infectious diseases and particularly your diarrheal illnesses become less prevalent. If we look at the South African context, we can see that the diarrheal diseases still are, 10th in terms of the causes of mortality. And this is based on this latest data. However, the one thing I would like to caution, perhaps we should consider, is that HIV/AIDS or AIDS-related issues remain the commonest cause of mortality. And perhaps some of these diarrheal illnesses, or at least some of these deaths, might be accounted for by the HIV population. So that's just something to bear in mind. So if we look at some of this table kind of summarizes some of the bacterial causes of infection in the gastrointestinal tract. And I just wanted to highlight maybe just a couple of concepts. If we look at the middle column and looks at the mode of disease, this kind of lends to how or the mechanism of diarrhea, or the mechanism of disease of these various organisms. So I did allude to it a little bit earlier, that you can have either invasion, intra-invasion, where you have invasion of the wall with the bacterium, and then this may or may not disseminate. And these are typically the organisms that we consider antimicrobials in, not always, but sometimes. And then of course, the other main mechanisms by which these infections cause diarrhea is through toxin production and the so-called introtoxic. And these are typically your secretory diarrheas. So you can see, based on whichever organism it is, you may have a specific symptom complex. And the mainstay of treatment that I would like to emphasize is symptomatic treatment. So that's rehydration as well as antidiarrheals. However, in some instances, and particularly in typhoid or salmonella typhi infection, that is when antimicrobials are always indicated. However, in other instances, that is only left to patients who are severely ill, those who have hemodynamic compromise, or those who have signs of systemic sepsis. So this is a algorithm that comes from the Antimicrobial Stewardship Guidelines. And effectively, it just shows that if you have acute diarrhea, if it is not requiring hospitalization, there's no dysentery, these patients should be reassured, and no antibiotics are required. As compared to our hospitalized patients, then we have to work them up, obviously. And importantly, we'd send our stool away. And then obviously, in the case of our immunocompromised patients, we must consider some of our parasites as well. And then in certain populations, we consider C. difficile infection, those who have been previously, had antimicrobial exposure. And so if these patients then turn out to, if they culture something, you will treat them empirically. And if not, then you might consider empiric antimicrobial therapy. And the regimen that we use, or that is recommended, is ciprofloxacin, as well as metronidazole, as shown there. And then a quick word on Clostridioides difficile infection. We know that this is quite a common infection, particularly of particularly a cause of healthcare associated infections. And this is associated with previous exposure to antimicrobials, but also previous hospitalization or residence in a healthcare facility. I'd just like to remind that there are other risk factors or other causes. We tend to see it quite often in our patients with inflammatory bowel disease, but there are other risk factors that are listed there. And what I wanted to emphasize here is that the update in the diagnosis of C. difficile infection. Importantly, the first thing is whom to treat, whom to even work up for C. difficile in the first instance. So it's important to have a positive or high positive or pre-test probability rather. And so these are patients who are at high risk, elderly patients, patients who have been hospitalized or in healthcare facilities, and patients who have some of those other conditions or recent surgery. And the diagnosis relies on a two-step process. And the main issue is demonstrating toxin. So what we have, and I believe what our lab does, is we have our two-step process using our GDH. And so you would send your stool in the at-risk population, or from this at-risk population. And then we will check if the GDH is then positive, we look for the toxin. And if the toxin is positive, then we have confirmed C. diff infection. If our toxin is not positive, then we can go into a second step, a second test. So we do a GDH and then do a nucleic acid amplification test or a PCR-based test. And see if that is positive, we have what we call as a toxigenic C. diff infection without toxin, or where toxin is not detected. Of course, if it's negative, then we have no C. diff infection. You can also do it the opposite way around, where you start with a PCR-based testing. If that PCR-based test is positive and you have toxin, then you've got C. diff infection. However, if that PCR-based test is positive and you do not have toxin, then you do your second, if it's not positive, then you have again what we call this toxigenic C. diff. And the significance of this is, it's interesting. I mean, there are a few instances where you can get false negative toxin. However, this is where you would consider some of the other causes of diarrhea. Perhaps there's medications on board, or perhaps retest. So once you have made the diagnosis of C. difficile infection, then we have to classify them into severity, as you can see there, based on the white cell count and the creatinine. And then, of course, if there is fulminant disease, you will have those features of shock or systemic toxicity. And this is an algorithm for the treatment. And what's really just been updated is initially the first line therapy for non-severe C. difficile infection was metronidazole, oral metronidazole for 10 days. Recent data has shown that it's inferior to vancomycin. So the latest guidance that we give vancomycin in the first instance. So, or indeed fidaxomicin if you have access to that. Metronidazole can be used, but this is reserved for cases where they are low risk. Typically, these patients are high risk anyways, but if you do have a case where a patient is low risk, who has low risk of recurrence, who it is an initial presentation of the C. diff, and of course, if we don't have availability or access to your vancomycin, in this instance, you may use metronidazole in the first instance. For recurrent C. difficile, it is all about vancomycin. If at a higher dose, if you've used previous vancomycin, and then we do what we call a pulsed tapered regimen. So once you've completed, then to taper down the dose. Alternatively, we can use fidaxomicin if you used vancomycin or metronidazole in the first instance. And then for further or subsequent episodes of recurrence, there are other modalities that I won't go into in this talk. So in summary, our GI infections are very, very common. Most of them are self-limiting and they are really fatal. Importantly, not always do they require antimicrobial therapy. And I'd just like to point you guys towards some of the guidelines. Certainly in our context, we have the South African Antimicrobial Stewardship Program guidelines. And then locally from our CMJAH GIT department, we have contributed to the EMG guidance guidelines. So you can find them on the app as well. So these are some of my references. And yeah, at this point, I'd